My name is Mina Sedrak, and I have the pleasure of moderating this wonderful session, educational session 11, Mind the Gap, Breast Cancer in Older Adult. We have three incredible speakers here today. Our first will be Dr. Lajos Pusztai from the Yale School of Medicine, who will be talking to us about the biology, the aging immune system with hormonal changes.
So I'd like to thank the organizers for inviting me to give you a very brief introduction about the biology of aging and how it might interact with the biology of breast cancer. Okay. Well, so this doesn't seem to work. I think there is a little bit of a lag. So this is my disclosure information. So most of these are not related to the current talk, but it's always a good idea to double check what a speaker does. So this slide shows you the number of new cases each year per 100,000 females by age brackets, and also the cumulative incidence of breast cancer as we get older. So you see that about 10% of all breast cancers in the United States are diagnosed in women who are 45 years old or younger. And about 20% of breast cancers occur in women who are 75 years or older. And the biology of breast cancer in these age groups is actually quite different. So in younger women, triple-negative disease is more common than in older women. Also, keeping all the stage the same, they have a greater risk of recurrence. So they have a worse prognosis. And at the same time, they also have greater chemotherapy sensitivity. So the question is, of course, so why some women develop breast cancer at a younger age, others at age 75 or older? And how do these biological differences between breast cancers in younger versus older women arise? So this is just to illustrate you this really sort of well-established observation that among younger women, triple-negative phenotype is more common. So in this particular study, of all breast cancers diagnosed before the age of 40, about 16% of them were triple negative, whereas over 75, this was only 6 to 7%. And of course, the flip side of this is that ER-positive disease increases proportionally, which is also very interesting, right? Because ER-positive or ER-dependent cancers develop at the time of a woman when the estrogen levels are the lowest. So I'm going to talk about three things very briefly, about alterations in endocrine sensitivity during aging, then changes in the immune microenvironment or the immune environment of the patient, and also about some of the accumulating mutations that are happening. So this is a plot of the hormonal milieu. So this first plot is very familiar to probably all of us. Gosh, yeah. So this is the estradiol and progesterone levels in the serum of women or young girls in the prepubertal state, and then during sort of the premenopausal status, and then around perimenopause, and in the postmenopausal state, when the hormone levels drop back below the prepubertal levels. So one important thing for those of you who are clinicians, so the usual estradiol measurements are actually focusing on this range. So if you really want to measure precisely the estradiol level in the postmenopausal woman to determine that postmenopausal, you need to have an ultra-sensitive estradiol assay. But so again, to show the sort of the flip side of what I have shown on the previous slide. So this is the frequency in another study of ER-positive disease by age. So the numbers differ, but the trend is exactly the same, right? So younger women have fewer ER-positive disease, and older women have more frequently ER-positive disease. But that's the really interesting part here. So this is the recurrence score value distribution. Actually, this is the recurrence score class distribution using the older version of the recurrence score from 2015. This paper is from the low risk, intermediate risk, high risk. And you can see that the ER-positive cancers in younger women actually have a different distribution of the recurrence score values than older patients. And they have fewer low risk and many more higher risk patients. So why is that? Or how does this arise? So just another thing about the biological differences. So this is a large sort of combined analysis of the neoadjuvant trials from the German breast cancer group. And you see that among the ER-positive women, the PCR rates, just like you would predict based on the recurrence score distributions that I showed in the previous slide, the PCR rates decline as you get older and older in an ER-positive disease. So from 11% to about 6% if you are greater than 50. So what might account for this? So a few years ago, we did the study when we looked at a whole lot of public gene expression databases like the TCGA, the other microarray cohorts, Metabreak, the ScanB, and asked 3 questions. So is there a difference in the estrogen-related gene expression signatures, the proliferation-related gene expressions, and immune-related gene expressions by age? And in this particular study, we were really intrigued by the RxPonder and TaylorRx results, right, which showed that younger women actually benefit from chemotherapy, even if their recurrence score is low. So their proliferation sort of is low, which drives much of the recurrence score high-risk population. So what's the difference between genomic low risk, younger women versus older women? So we looked at the ESR levels. It's very clear, and you can see this here, that the ESR, the mRNA expression levels for the receptor, are actually lower in younger women than in older women. The proliferation metric, Ki67, was the same because we selected the population to be like that. But that's also very interesting, and I'll get back to this later. The tumor mutation burden actually is higher in older women. You can explain that very sort of simplistically, that they are older and they accumulated more somatic mutations. But the really interesting part is this one. So these are the immune-related signatures and the estrogen-driven genes, or estrogen is a transcription, estrogen receptor is a transcription factor. So all the ER-driven genes are actually lower in younger women. That's the mean compared to the older women, right? So older women have a higher ER sensitivity and ER sensitivity signatures. But at the same time, all the metrics, the immune-related metrics, are actually lower. So we wanted to ask an additional question about the ER. So your ER mRNA could be lower because each of the cells have a lower level of mRNA or ER expression and lower ER sort of related gene expression, or you could have a lower bulk ER because actually fewer cells are ER positive. So there are more commonly ER 10%, 20%, 30% positive. That was the question that we wanted to ask using this large TCGA data. And what this shows you is that actually it's the expression level of the ER and the ER-related genes at a cell level that's lower, not the percentage of cells. So as if the percentage of cells would be increasing, so the ER positivity, percent positivity increased by age, then you would see something like this, an increasing line. But we don't see that. It's a totally flat line. So the ER percent positivity distribution is the same. Across the age groups, it's the actual ER expression at the cell level that's less. But the really interesting thing is that if you plot these 2 things, the main differences between younger women and older women in this genomic low-risk population, the 2 things that differ, the ER-related signatures and the immune signatures, when you plot them in sort of 2 dimensions relative to each other, then you see that most of the older patient population have sort of these high ER levels, and really few of them have high sort of immune presence. And it's a distinct population. There is a population here that is low in the ER, relatively speaking, but high in this B-cell signature, immune signature. So that's relevant because this creates a therapeutic hypothesis, right? So the clinicians among you are all wondering about this. So is the chemotherapy just a fancy way to do ovarian suppression, right? And that's what drives the chemotherapy benefit in the younger women. And it's probably not the case. So I think in the younger women, the younger population actually has 2 groups. A group where the chemotherapy has a genuine effect, whereas this effect is not seen in the older population because of the high endocrine sensitivity and lack of immune presence. That's, again, it's been seen by other investigators as well. So what I showed you is gene expression signatures of immune genes. These are correlate reasonably well with TIL counts. Many of these genes are actually very highly specific to the immune system, right? Immunoglobulins and things like that. So, of course, there is a very similar relationship between age and TIL counts as well. But there is great variation by chronologic age. But by and large, there is a significant sort of downward trend in terms of TIL counts by aging. So on average, younger women have higher TIL counts in both ER-positive and triple-negative disease than older women. So why is that? So before I move on to the immune senescence and how our immune system changes over age, just want to sort of show you this hypothesis that what we think is happening is really that the greater estradiol sensitivity and the greater expression of the ER in older women is probably a classical sort of hormonal regulatory feedback. As your hormone level is declining, the receptor level is increasing, and the sensitivity and the signaling through the receptor is increasing. So that's the reason why older women may be so highly sensitive to the endocrine manipulations. And the lower TIL signatures actually bode well for a lower sensitivity to chemotherapy. Now we really see a lot of data that higher TILs are always going hand in hand with the chemotherapy sensitivity. Part of the chemo effect is mediated by the immune system. So this is what's happening to the immune system over aging. So just like the hormone levels change in women, also in men, so our immune system also undergoes changing. And it's a very dramatic thymic involution. And with that, there is a very dramatic drop in naive T cells in our blood and also in our tissues. But at the same time, of course, memory T cells and memory B cells increase because we have been exposed to so many various sort of infectious agents over time. But along with this decline in the naive T cells and increase in the memory T cells and B cells, there is also a slight imbalance in the way these cells actually secrete cytokines, and there's a tilt towards a pro-inflammatory cytokine sort of output. And you know that many studies show that in COVID, people didn't die because of an overwhelming sort of viral infection, but they really died because of a dysregulated cytokine storm or a really inflammatory response that didn't have the proper feedback to suppress after the infection. So all of these components, when you study them, that really sort of account for the adaptive immune system is declining with aging. So there are fewer antigen-presenting cells, and their activity is less. The T-cell receptor signaling coactivated molecules decrease in the co-expression on the surface increases, and with that, T-cell receptor signaling declines. And also there is a decrease in the sort of adaptive cytotoxic activity of the cells. So these are just some of the markers of immune senescence on immune cells. So I highlighted you a couple of things. That there is really a change in the cytokine sort of profile that senescent cells produce. And that's also happening in the stroma. I'll show that to you on the next slide. But usually all the bad actors that are associated with less robust immune system and less well-coordinated immune system are up where you are aging. So what are these? TGF-beta, IL-10, IL-8, IL-6, TNF. And but the real challenge is that just like any organ aging, the immune system aging doesn't completely match your chronological age. In fact, there could be huge differences because there are many other things besides age that influence the senescence of cells in the immune system, but so in other organs. So exercise matters. There is a lot of data that actually regular exercise increases not only cardiovascular health, but also immune fitness. And I don't have time to show you all this data, but I did put there the references for you. The same, so it's very clear for gender influences are how our immune system actually is aging. And there is a delayed aging of the immune system or delayed senescence in women relative to men. So many of the changes that men go through happens 5, 6, 7 years later on average in women. And one of the hypotheses for that is the biallelic sort of expression of X-linked immune-related genes that could mediate this. And importantly, so the aging of the stromal cells, senescence of the stromal cells have a direct influence on the tumor microenvironment in terms of the immune presence there. So there is a very interesting sort of phenotype that's called senescence-associated secretory phenotype, which is characterized by secreting relatively immunosuppressive and pro-inflammatory cytokines in the stromal cells that, of course, have an impact on the tissue-resident cells. But the main message really is that so due to the highly individual combined effects of all these factors, there is no age cutoff to define an immune young or immune old individuals. And one of the unmet sort of needs in this field is to really become very accurately determine chronologic age, right? We need something like that to actually measure sort of immunological age or immune senescence in order to be able to really sort of measure the impact of this on outcome. Because if you just take age, then remarkably, it turns out that immunotherapies actually have a similar efficacy, whether you are young or old, but who's younger, who's old. So most of these studies use a chronological age cutoff, 65 older or 65 or younger. And when you look at these studies, most of them really show that regardless of the age, the immunotherapy benefits folks. So these are basically plots for the younger versus the older age groups, and these are the studies that compared the immunotherapy versus the control, and it's all on this side, right? So it's a very similar distribution across these individual studies, which indicates that they really behave the same way. The immunotherapy behaves the same way and provides the benefit when there is a benefit in both age groups. There may be one example which is sort of intriguing, and it's melanoma, where oftentimes a couple of studies have shown that melanoma, maybe younger patients, seem to derive greater benefit. So we're going to talk a little bit about the other component that goes into aging, obviously, which is acquired somatic mutation burden, which contributes to the increasing risk of developing cancer with age. So a few years ago, we did a really simple study. We just asked this question that, you know that there are a bunch of genes which are important for cancer. We call these cancer hallmark genes, which are sort of these canonical genes that have biological sort of validation for being important in some sort of a cancer-related function. And we curated these 1,500 or so genes, and we asked this question that how often these genes actually carry a protein function-altering germline mutation, and how often these genes carry a protein-altering mutation in a somatic or acquired manner. And this is and we grouped the patients by age groups. And this is what you see here. So this is the germline variant burden in these 1,500 cancer-related genes by age. So these are age groups by cohort, I think brackets of 5. And then you see that if you develop cancer, any cancer, at the age of 30 or younger, then you have a high burden. And this burden decreases, germline burden, as you get older. So in other words, people who develop cancer at an old age of any cancer, this is the TCGA pine cancer data, they actually are born with a sort of a healthier genome in terms of alterations in their cancer-relevant genes. But at the same time, as you get older, the mutations in the tumor, somatic mutations in these very same genes, starts to accumulate. So the idea is that, and that's really interesting, but of course, when we look at pathways that you need to be altered, the hallmarks of cancer that need to be altered for a transformation, and you say, okay, this pathway have 200 genes, what fraction of these 200 genes are altered at the germline level or somatic level? Then you see that picture. So these are different cancers. So this is skin cancer, highly associated with ultraviolet exposure, right? This is lung cancer, smoking. That's bladder cancer. So these are here, these head and neck cancer. So the ones that I highlighted in red are cancers which are associated with carcinogen exposure. And in these pathway alterations are dominated by this sort of black color, and the black color corresponds, oh, you can't see that here, right? So the black color corresponds to somatic mutations. Now, these cancers here, this is my favorite, it's breast cancer, right? So here, the pathways, so each column here is a pathway. I'm not sure if you can read this, but these are things like, I can't read it either, but DNA repair or pathways of the PI3 kinase or P53 and so forth. So in these pathways, the dominant source is oftentimes germline rather than somatic, whereas in carcinogen-induced cancers, the dominant source of the alteration in the genes in all of these pathways is acquired, right? And that's very nice. So that just gives like a sanity control that this is really how this is happening. But that's really important because the idea that you could use this association maybe to develop a tool that sums up all your germline variant abnormalities and makes a prediction about at what time or what age a person would be at risk to develop cancer. So it's kind of your cancer gene system's integrity that you could measure by summing up all these germline variants and create a risk prediction tool that might be more effective or complement the current sort of polygenic risk scores, which don't perform that well. So to conclude this, so breast cancers arising in postmenopausal women differ from cancers in younger women. These are more often ER positive, they show greater endocrine sensitivity, and on average have a lower recurrence score, and this greater endocrine sensitivity is largely mediated by higher expression levels of the estrogen and the estrogen receptor. And the estrogen receptor regulated or estrogen regulated genes that are consistently associated with greater endocrine sensitivity. And on average, older women have lower TIL infiltration and a lower sort of immune activity in the microenvironment of the tumor. So they have more of an sort of an immune inert phenotype. So the biological reasons for this greater endocrine sensitivity are this higher ER expression level, which I think is really just the manifestation of this classical hormone sort of feedback mechanism. As your hormone level drops, your tissue sensitivity goes up. And the differences in the TIL distribution by age doesn't translate to differences in IO therapy sensitivity currently, but I think that's because age doesn't really capture so well, particularly not the way we dichotomize these folks into 65 or younger. It doesn't really capture the sort of the true immune senescence or immune age of a person. And I think this was my last slide, so thank you.
Our next speaker is Christina Minami from Brigham and Women. Her title of her presentation is Defining and Avoiding Low-Value Surgical Therapy.
All right, thank you, everyone. And thank you for the committee for the opportunity to speak today. I don't have any disclosures. So, I've given some iteration of this talk repeatedly over the past 5 years, and unfortunately, every time I update my slides, I have to keep adjusting this number upwards. And so it may be no surprise to this particular audience, but over this past year, over 310,000 new cases of breast cancer were diagnosed in the United States. And as cancer is a disease of aging, over 45% of these new diagnoses were in women who were 65 and older. Now, as our overall population is continuing to age, the coming of this so-called silver tsunami is just going to increase the proportion of our breast cancer cases that are in older adults. And now, the older adults with breast cancer that we see, approximately 70% have very early stage or localized disease, making it a very relevant population for surgeons, medical oncologists, and radiation oncologists alike. Now, one of the reasons why I became interested in this particular population is because choosing optimal treatments can be very nuanced given the physiologic differences in a given individual. And so over-treatment and under-treatment is thus very difficult to define on a population level because it has to take into account the particularities of a given person. And I would say this is the challenge of providing tailored care overall to any breast cancer patient, but I would contend that in older adults it can be even trickier. And these are the best definitions of overtreatment and undertreatment that I've seen in the literature. This is from a scoping review in JCO, and it depicts overtreatment and undertreatment with respect to the given vulnerability of a patient. So in this particular figure, you can see robust and fit on the left, frail and unfit on the right, and then the relative benefits and harms of a given intervention here on the y-axis. And so you can think of undertreatment as one of two things. Either use of less intensive cancer treatment in a fit older adult who would derive greater net benefit from more intensive therapy, or, and I would contend that this is the one that we tend to forget about, not providing non-oncologic interventions for deficits in geriatric domains regardless of what therapy is chosen. Overtreatment, on the other hand, can be thought of as mismatch between intensity of cancer therapy and the vulnerability of a patient, or cancer therapy without benefit in an older patient's remaining lifetime. Now, this talk is supposed to focus on low-value treatments, especially low-value local regional treatment in early-stage breast cancer. And to define that, we can think of the classic value equation as quality over cost. And in this demographic, we have to think about how undertreatment and overtreatment each have a different bearing on the quality-cost relationship. And I'm not going to talk a lot about costs today, so we're going to frame the discussion of value more around quality of care. And we need to think of this by tumor subtype. So first, we're going to talk about some of the de-escalation literature in the ER-positive, HER2-negative setting, which tells us that some of our interventions have very little benefit for a fixed cost, both to the system and to the patient. And then the HER2-positive, triple-negative arena will focus on how to possibly prevent low-quality surgical care. But let's start with the hormone receptor-positive, HER2-negative subtype, which, as we know, is the predominant subtype in women of all ages, but it's even more predominant in the older population, as approximately 75 to 80% of patients over 65 are of this subtype, compared to about 65% of patients who are under 50. And when we think about the options available to this population, well, there are certainly a lot. So here I've laid out a little bit of the menu that these patients can choose from, least aggressive here on the left, more aggressive on the right. So first off, there's a decision as to whether or not to even do surgery. If so, what type of breast surgery, whether or not to do a sentinel lymph node biopsy. And then there's the possibility of omitting radiation. And all of our existing trial data all included endocrine therapy, so that's often taken as a given. Now, given all the trade-offs that I've listed here, I think that it can be a pretty nuanced decision. But before we really get into the gray areas, let's go quickly through some of the black and white trial data that we have. So first off, primary endocrine therapy. These particular trials really break down into two major groups. So the trials that looked at surgery plus endocrine therapy versus endocrine therapy alone, and then those that looked at surgery alone versus endocrine therapy alone. And in this table, I have one study representing the former trial group and then one study representing the latter. The first, the Greta trial, randomized women who were 70 years and older with operable breast cancer to surgery plus tamoxifen versus tamoxifen alone. And like the rest of the data in this area, there was no difference in terms of overall or breast cancer specific survival, but there was increased progression-free survival in the surgery arm. You can see the rates of local progression listed here. Similarly, the ERTC 10851 study randomized women with operable breast cancer to modified radical mastectomy versus tamoxifen alone. And again, they found no difference in overall survival, but there was increased median progression-free survival in the surgery arm, and they also provide median time to progression. So in surgery, it was about 5 years, whereas in the tamoxifen-only arm, it was just over 2 years. And so I think this is why in the US, we tend to think of primary endocrine therapy as a tool really to be used in patients with a very short life expectancy. Which begs the question, well, how do we even estimate a patient's life expectancy? None of us have a crystal ball, but there are some validated calculators out there that can help us to get beyond the eyeball test. And I'm going to spotlight one of the tools that we have here. It's easily available on eprognosis.ucsf.edu. And the one that we tend to use in our own clinics is the Lee-Schoenberg Index. It's a calculator that was developed in community-dwelling adults, and so I think very applicable to our particular patient population. And this particular index is derived from 15 different items. Some of these items you can get just from the EMR, but some of them you do usually have to ask of the patient when they're in front of you. And for a given number of points, you'll get the corresponding mortality risk at 5, 10, and 14 years. And you can see down here that this will tell you that patients that have a greater than 50% chance of death in a specific time interval have an estimated life expectancy less than that interval. And I think we have to keep this issue of life expectancy as context as we really move through the rest of our trial data in this particular population. After all, in the setting of omission of axillary surgery and radiation, we do see small differences with respect to local regional recurrences, but in order to even realize those differences, a given patient has to survive a certain amount of time. And so the two randomized controlled trials in terms of omission of axillary management in this older adult population are listed here. First off, we have the IBCSG 1093 study, which randomized women who are as young as 60 years old with clinical T1 to T3 node-negative disease to breast surgery plus axillary lymph node dissection and tamoxifen versus breast surgery and tamoxifen alone. At median 6-year follow-up, no difference in disease-free or overall survival, and the axillary recurrence rates were very low, so 3% in the no ALND arm and 1% in the ALND arm. Martelli et al. Similarly took a look at older adults who were 65 to 80 years old, a little bit smaller disease, T1N0, and they were randomized to quadrantectomy plus radiation plus axillary lymph node dissection versus quadrantectomy plus RT alone. Again, we're not seeing any differences with respect to survival and single-digit axillary recurrence rates, so 6% in the no ALND arm, 0% in the patients who had a dissection. And any of you who know the data in this particular area, you know that we tend to cite CLGB 9343 as backing for omission of sentinel lymph node biopsy in this particular population. But of course, we have to remember that it was fundamentally an omission of radiation study. And so that took a look at women who were 70 years and older with clinical T1N0 ER positive disease, randomized them to lumpectomy plus radiation plus tamoxifen versus lumpectomy and tamoxifen, but axillary surgery was discouraged. So there was no axillary surgery in over 60% of patients. This was equal between the two trial arms. Again, we're not seeing any differences with respect to overall survival or distant METs, and the axillary recurrence rates very similar to what we saw on the previous slide. And then, of course, we also have PRIME 2, which looked at women who were 65 and older, tumors less than 3 centimeters, and pretty low-risk disease. They couldn't have both LVI and grade 3 disease to be included. And at 10-year follow-up, no difference with respect to overall survival or distant METs, and the local regional recurrence rates very similar to what we see in CLGB 9343, so about 1% in the RT arm and 10% in the no RT arm. Now, all of these trials included endocrine therapy, but as we look at ongoing studies, the necessity of endocrine therapy is really being questioned, as the largest benefit really seems to be from local control rather than distant control. And I had to scramble to update my slides from Europa this morning. I was very excited to see this reported out. Of course, the follow-up is very short at 24 months, but I think it is very encouraging to see that in this particular trial, the RT arm had a better quality of life and lower rates of treatment-related adverse events. And of course, I think a continuing theme in all of this literature is that we do see relatively high endocrine therapy discontinuation rates, and it was 12.4% at only 24 months in this particular study. And so let's go back to our summary of decisions faced by older adults in this particular population. So surgery versus not, type of breast surgery, sentinel lymph node versus not, radiation or not, and even with long-term follow-up and without long-term follow-up trial data, many of our patients ask whether they really need the endocrine therapy. And so we've gone through some of the trial data here, but putting these into practice and really applying them to a given patient can make for very complicated discussions. And all of our large database studies would tell us that we still have relatively high rates of sentinel lymph node biopsy rates, which are as high as 80% in recent studies, and radiation rates in this population is also hovering around 65%. In addition, there are other options that are popping up. So we heard this morning about some data about endocrine therapy and ablative radiation with omission of surgery. And then there's also been a resurgence in interest in cryoablation with the publication of the ICE3 study. And in that study, the median age of the patients was over 75. And so most people have taken to applying that particular data to an older population with relatively small ER-positive cancers. I think how we're really going to operationalize these options on a large scale, though, I think really remains to be seen. But all of this is to say that guiding our older patients through their treatment options is only going to get more complicated. And this puts a lot of pressure on our abilities to communicate and educate our older patients about their viable treatment options and helping them to make a decision that's really consistent with their own values. And so some shared decision-making tool support really may aid with this. I think there are a lot of people who are working in this field, but I'm just going to spotlight this one example. This was developed by Maura Schoenberg, who is also the developer of the Schoenberg Index. And this particular patient-facing decision aid is specifically for women 70 years and older with stage 1 ER-positive breast cancer. And there's 2 parts. So part 1 really focuses on the surgery and radiation decisions, with part 2 focusing on the hormonal therapy decisions. And what sets this particular decision aid apart is that it's not only written with low literacy principles and geriatric specific preferences in mind, it depicts data in pictograms, so it's relatively easily understandable. But I think most importantly, it integrates health status into this data. And so patients on the first page can go through a modified Schoenberg index, and it allows them to self-categorize into different buckets of health. And then as they go through the rest of the decision aid, it will contextualize a given decision, such as, should I have radiation treatment after a lumpectomy, with respect to their health status. For instance, it will say for women in fair or poor health, the chance of dying in 10 years from their other health conditions is often much greater than their chance of dying from this type of breast cancer. Therefore, women in fair or poor health, the chance of harm from radiation usually outweighs the chance of benefit. So that's a very brief lay of the land in terms of the ER positive, HER2 negative landscape. What about low-value surgery in the HER2 positive and triple negative arena? Well, there are certainly fewer patients in this age group with this higher risk subtype, but they still constitute about 20% of our patients. And I would contend that these can make for actually some of the most difficult decision making. After all, what trial data do we have to support the omission of surgery in these particular subtypes in the older population? Well, there really aren't any. There's been some work in omission of surgery in exceptional responders to neoadjuvant chemotherapy, but that was overall a younger population than what we're talking about here. And often in our frailer older adults, what we're really trying to understand is whether they're really going to stand up to chemotherapy. But in the absence of data from these large randomized clinical trials, what should guide our treatment decision making? Well, I had to bring up the geriatric assessment, right? We always have to come back to this. As there's been growing evidence in the literature that these geriatric assessments can help to increase communication satisfaction, chemotherapy completion, quality of life, and cost savings. And so as of 2018, ASCO recommended that the geriatric assessment should be used to identify vulnerabilities or geriatric impairments that are not routinely captured in oncology assessments. And the GAs will give you a more complete picture of what an individual actually functions as. And so it hits on a number of different domains. So cognitive status, functional status, comorbidities, nutritional status, mood, medication review, environmental review, as well as their social supports. And in the latest update of the ASCO recommendations, it was pushing the practical geriatric assessment. This particular tool is basically in two parts. So the first part is 3 pages of questions to be completed by the patient or caregiver prior to their appointment. And then when they come in, there are some tests that the practitioner needs to run them through. So 4-meter gait speed test, nutrition question, as well as the mini cog. And then there's an option to also take them through a chemotoxicity calculator. But once you have this data, I think applying it can be relatively difficult for some people. You do have to think about what does the whole assessment tell you, and what does the individual deficits in different domains tell you. Well, let's go back quickly to our definitions of under-treatment and over-treatment, because I do think the geriatric assessment is key in avoiding both. So the assessment can give us an idea of the given fitness or vulnerability of a patient and potentially allow us to make judgments about the mismatch between this and the intensity of intended therapy. And to be a little more prescriptive about it, so you can get some summary scores from a GA, right? So if a patient has deficits in multiple domains, then this frailty can guide you with respect to risk assessment and treatment decision making. And in the surgical literature, frailty is associated with higher risk of reoperation, wound complications, major complications, non-home discharge, readmission, mortality, even in low-risk surgery, which is certainly what we tend to think of our operations as. And as you also saw on the previous slide, the chemotoxicity calculators can also be helpful. And this is a particular chemotoxicity calculator for patients with breast cancer. You can see the factors that go into this calculator here. And then it'll give you an idea of what a patient's given risk for a grade 3 to 5 chemotherapy toxicity is. And this is, of course, a good tool for our medical oncology colleagues, but I would also encourage surgeons to really think about integrating this into their practice when thinking about the order of therapy in some of our frailer older adults. And so these data are helpful for some of the initial treatment decision-making, but we also have to come back to this second definition of undertreatment, this idea of not providing non-oncologic interventions for deficits in the geriatric domains. Now, as surgeons, I think our concern first and foremost focuses on the physiologic stress surrounding surgery. And just as an example, at the Brigham, which is where our Dana-Farber patients tend to have their surgery, we have a superior surgical treatment for seniors pathway set up. And it starts with frailty screening in our outpatient clinics and in our pre-anesthesia evaluations. We use the Frail scale for this. And those who screen in Frail can then undergo a preoperative evaluation with a geriatrician and then be co-managed in-house by them as well. For all patients 70 years and older, frail or not, there's also order sets that are available throughout our hospital network. And these have been specifically implemented at the main Brigham as well as our Faulkner Hospital, where we do the majority of our breast surgeries. And these order sets include a number of different items. So we can easily order nutrition labs, orthostatic vitals, bowel regimens, specific pain regimens and aspiration precautions. One thing I will highlight here is the pain regimens, because they do represent a departure of a lot of our ERAS pathways. So we tend to lean very heavily on non-narcotic pain medications in these ERAS pathways. But in this older adult population, we want to try to avoid gabapentin and NSAIDs. And so this particular order set leans heavily on low-dose opioids and very carefully timed Tylenol. So it's dosed with ideal sleep schedules in mind, 650 milligrams PO from 8 a.m. to 8 p.m., and then allowing our older patients to sleep through the night. A lot of the implementation of this really relies on nursing care. And so you can see that we're very careful to make sure that our nurses have a lot of buy-in into this. We can order some consults. As I mentioned before, the geriatrics team can follow some of these patients in-house if they are frail or if they have dementia. Physical therapy and nutrition are certainly involved. We get social work involved if they live alone. And then if length of stay is over 5 days, which is pretty darn rare for our breast patients, but if they are there, then reminders for a family meeting are triggered. And then upon discharge, we're very careful to provide fall prevention education, and PCPs are notified so that they can have very short-term follow-up for a medication review. Now, that's really great for support throughout the perioperative period, but what about the longitudinal treatment experience from initial consult through survivorship? Well, we are very lucky at Dana-Farber. Thanks to Dr. Rachel Friedman, we have an older adults with breast cancer program. And this really leverages some of our existing resources at Dana-Farber, using the geriatric assessment to then provide the proper referrals. And there's also an embedded geriatrician within this particular program. And you can see some of the factors that will trigger a referral to her here. And to be more concrete, what can be done on the level of the deficits of an individual domain? Well, let's go back to the ASCO recommendations, because they do have a very nice table that illustrates this. And so this is an example for someone who has difficulties with physical function. And so if you screen someone and you find that they have these particular deficits, well, then there are very prescribed recommendations that you can follow here on the right-hand side. And so I give you an example of what we have at our own institution, recognizing that we are a high-resource setting, and even then there are certainly flies in the ointment. But looking beyond the walls of a given institution, when we think about providing high-quality care for our older adults as a whole, if we were to be aspirational, what would this really look like? Well, could we bring together all providers with the patient, discuss all the data that we have at hand, both the cancer-specific data as well as the geriatric assessment, and then come up with a treatment plan and specific interventions and referrals? Well, that would be great, right? But we have to contend, in reality, this is really what care looks like, right? Consults are spread across space, time, and hospital systems. Each provider at the time that they're seeing their patient may be working with a very incomplete set of data. There's no time for these geriatric assessments. People don't really know what to do with the data from the geriatric assessments, even if you do have them. And then even if you have those two, both the data and the know-how how to use it, well, you might not have any resources to actually address those deficits. And so my first piece of advice comes to my 3-year-old. Do a little bit of rainbow breathing. This is actually really good for just calming down. And then I would say we just have to roll up our sleeves and accept that there's a lot more work to do. And we can certainly call for more data, right? And we definitely need more clinical trials participation from the older adult population. But then we're also still struggling just with implementing existing trial data, and we have to work on that as well. We need to continue implementation efforts around the geriatric assessment, and that includes educating all oncologists on how to use the data from the GA to guide treatment conversations in both low-risk and high-risk disease settings. And then, of course, pursuing effective interventions targeting care fragmentation and barriers to effective multidisciplinary care. And so with that, I'm just going to leave you with a moment of Zen. Thank you very much.
Thank you, Christina. Our next speaker is Dr. Hans Wildiers from the University Hospital of Leuven, who will be telling us about systemic therapies in older adults.
Okay, good evening, and thank you for coming to this session, and also thanks for the organization to organize a session on older adults, because it's really becoming a big problem for all of us. It's not a niche specialty, it's something that we all need to know. This is my disclosure slide paid to my institute. So this is the overview. I will give a general introduction and then focus on systemic therapy use in early and metastatic breast cancer. So we heard already about the silver tsunami. There are different ways to look at it. This is UK data, again showing that in less than 50 years there will be a doubling in the number of cancers in the UK and the Western world, largely driven by older persons. We will all see much more older patients with breast cancer, so we all need to learn. We all need to be geriatric oncologists, we need to be geriatric radiation oncologists, surgeons. We don't need separate units for this. I think we all need to know the principles when we treat patients. Major challenge, as we heard, is the huge variability in general health status that has a huge impact on life expectancy. This is one of the landmark trials by a geriatrician, Louise Walter, who made predictions of life expectancy depending on the frailty or the fitness status. And an 80-year-old person can have a expected life expectancy of 3 years if it's a frail person within the lowest 25 percentile, or can have a life expectancy of 11 years if that person is fit. This has huge impact on the oncology treatment decisions that we take or have to take. So if you ignore this in your approach, I think we are not giving good care. Now, this variability can be measured best by a geriatric assessment, as we heard. We don't have time to give you all the trials, but I have 2 slides summarizing all the evidence I think that is out there, and there is a lot of evidence that geriatric assessment helps in care. I put 2 references. These are 2 reviews, recent reviews that give a very nice summary of all the data and the trials that have been ongoing. So first of all, if you do some kind of geriatric assessment, you detect a lot of problems. A lot of problems that you are not aware of if you don't do the assessment. You don't immediately see if there's a cognitive problem, and if you don't have attention for it, you easily miss it. A geriatric assessment changes treatment plans. If you ask oncology teams to make a treatment proposal, and then you give them the data of a geriatric assessment, the teams change their advice. Depending on the trials, in 10-20%, they may come up with less or more treatment based on the results of geriatric assessment. It has very important prognostic information, geriatric assessment, as I showed you in the previous figure. It has been shown that it improves communications on the goals of care. It predicts chemotoxicity, it predicts functional outcome, and last but not least, it leads to interventions. Because what I show you now is the benefits just by doing a baseline assessment. But in the last 4 years, we have seen a number of randomized trials looking at what if we do something with the information that we find in our geriatric assessment, if we approach the nutritional problems that we find, if we look at the social problems, the cognitive problems. Well, randomized trials show that if you do such an intervention, that you decrease the toxicity of your chemo, if you give chemo, that you improve functional outcome, you improve the likelihood of completing your treatment, and you improve quality of life. I think the evidence is out there that we have to do this, but it doesn't happen in many clinics, unfortunately. And the major challenge is how do we implement this in practice? And in our institute, we are focusing strongly on this. There is certainly not one way to implement it. It will depend strongly on your healthcare setting. ASCO and CARC developed a nice practical assessment. But in Europe and in many centers in Europe, I think also the concept of geriatric screening tools is used quite often because it's a quite effective way to have at least some attention to this domain and then to dive more deep if there are problems. And the G8 screening tool is the best studied and probably the best validated tool in older patients with cancer. It takes 2 minutes to complete, and it gives you a score from 0 to 17. And if the score is above 14, these are patients that are considered fit, because if you do a full geriatric assessment, you find not much problems. These are patients that are generally quite good. But if it's 14 or lower, you have a high chance of finding problems at a more in-depth geriatric assessment. And in breast cancer, the distribution is about 50-50, but in other cancers, it's much higher. In head and neck cancer, it's 80% that have a frailty risk. So, of course, it's a very short screening tool, and it's certainly not enough to give to your patients. But if you have a good G8, you can do a more in-depth geriatric assessment, but you can often give standard therapies. You need to be attentive because patients can become frail. But I don't think the biggest benefit of in-depth geriatric assessment is in that population. On the other hand of the spectrum, you have the very frail patients that come in a wheelchair. They come from a nursing home. They are heavily demented. You can do a geriatric assessment, but these patients often already have quite some care around them. The treatments that we give is, or we give nothing, or we give a tablet of letrozole. So I don't think it's highly efficient to send these patients to a 1-hour consultation in the geriatric department. I think the most benefit is the ones in between, where that have some vulnerability, where you think about therapies with potential impact, and it can be surgery or chemo or radiotherapy, and their geriatric assessment often can give much more details on the problems. And in our institute, we are like most Belgian hospitals, general hospitals with large geriatric departments, and we can refer them to geriatric day hospitals for evaluation. Which is probably different in the US, where that are often oncology-only clinics. It's not moving anymore. Maybe the battery. Yeah. Okay, so we heard already a little bit about biology. We heard a lot of interesting data from Lajos. But from a clinical perspective, a summary, so the subtype distribution is really different, as we heard. Also, the genomic landscape seems to differ with age, in terms of mutations or ApoBec signature, for instance. We also showed and validated that when you correct for tumor size, that older patients have much less lymph node involvement. And we don't know why this is, but is it because the lymphatic vessels also age or are less effective in transporting tumor cells? We don't know, but it's a remarkable observation. Also, the tumor stroma changes, as we heard, the senescence-associated secretory profile is more present, and immune infiltration in most subtypes decreases. At ESMO this year, we heard for the first time also data on biology in metastatic breast cancer. It was the Aurora trial under the umbrella of the Breast International Group that showed that with increasing age, there are specific mutations, actionable mutations that are more present, like PIK3CA or ESR1. There are also potentially actionable acquired mutations that are more frequent, like BRCA2, and the hedgehog signature seems to decline with age. So we cannot say that these tumors are all the same. It doesn't have any impact yet on our clinical care, but it's certainly an interesting area for research. So speaking about systemic therapy, the first data on this issue came from chemotherapy, and there's a lot of good data that the pharmacokinetics of drugs that you give change with age. Older people have worse absorption of oral drugs. More importantly, the distribution volume of water-soluble drugs decreases. So if you give the same amount, the concentration will be higher and give more toxicity. For renally excreted drugs, the renal function declines with age. So these are all factors that probably play a role in the observed increased toxicity. Many trials show that if you give the same drugs and doses to older patients, you have more problems. This is from the SEER database showing that in real world, or Medicare, that you have more than double amount of hospitalizations when you give the same chemo regimens. And this is something that has frustrated me a lot in the last decade. We hear at congresses very frequently age sub-analysis, 65 plus versus less than 65. And then often there's not a strong signal, and then the message is that the drug is well tolerated in older persons. But this is really ignoring that in these pivotal trials, we hardly have frail patients. It's always a selection of a few fit older patients. I will give you some examples. So we can't state on these pivotal trials and age sub-analysis that these drugs are feasible in an 87-year-old frail person sitting in front of you. And this is an example. This is 7-8 examples of trials demonstrating that older patients are systematically excluded from trials. And this is pharma trials, like Catherine Ascent Tropics trial. You see that the number of 65 plus patients is low, much lower than what we see in the general population. And the 75 plus population is extremely low, while we see them in our clinics. And it's not only industry trials, it's also Mindex, TaylorX, also there for different reasons. We see very low numbers of older patients involved. And it's always difficult to extrapolate the findings of these important studies for frail older persons. So moving to early breast cancer. The first observation is that older persons receive much less systemic therapy with increasing age. This is a SEER database, real-world study showing that chemotherapy is much less used in ER-positive, node-positive stage 2 breast cancer. But it has consequences, because in the same study, they looked at death and cause of death, and they saw that in the 85 plus, there was a 4 times higher risk of death from other causes. This is what you expect. But there was also a 50% higher risk of dying from breast cancer, indicating that if we undertreat patients, they may die more often from breast cancer. On the other hand, a sizable proportion of older people with operable breast cancer will die from non-cancer related causes. This is a nice study from the Netherlands Cancer Registry, looking at patients that died within 5 years after breast cancer diagnosis, and then they looked at the cause of that. And if you're 30 years old and you die within 5 years, the cause of death is in 99% the breast cancer. But if you're 85, cause of death is breast cancer in 30% of patients. So it's difficult because older people can die from other causes, but can also die from breast cancer. But anyhow, if we treat all older patients exactly the same as younger patients, we will be over-treating enormously because a large proportion will die from other causes. So how do we select older patients with early breast cancer for therapy? We rely on the factors that all breast specialists know: the tumor extent, the tumor biology. But for older patients, there is more focus needed on patient preference and on general health status, as I explained, on life expectancy, on expected tolerability of therapies. And since a few years, we have some nice tools available that we can use in the clinic. I think we all use the PREDICT tool. It's a good tool to predict the benefit of chemo and endocrine therapy, but it does not integrate at all geriatric aspects. So if you have a very fit or a very frail person in front of you, I'm sure that the outcome will be different, and it's a major disadvantage of the PREDICT tool. And in the UK, they developed the age gap tool, a very nice tool that you should use in your clinic because it's specifically designed for older people, and it has two purposes. It can give you the 2 and 5 year survival benefit of primary surgery versus primary endocrine therapy. Or secondly, it can predict the value of adding chemo in your patients. It's specifically developed for 70+ patients, and it takes into account the fitness or the frailty of your patients. So use it in your clinic. You have the CARC breast cancer tool that was already explained that can predict grade 3 to 5 toxicity from chemo. It's a very good tool to use. It doesn't make a distinction between hematological and non-hematological toxicity, but still it can give valuable information. And I am waiting for the online availability of the Portrait trial, Dutch trial, because it's published already. It's a very elegant tool that I will certainly use in my clinic because it predicts 5-year recurrence, survival, and other cause mortality accurately by integrating geriatric components. And I heard from Nienke de Glas, who helped developing this tool, that it's a matter of months that the tool should become online, and that I will certainly use it in my clinic as well. So what about chemotherapy in older persons? There have been a few studies looking at this question, and the first landmark trial is CLGB 49907, evaluating adjuvant standard chemo, which was AC or CMF at that time, versus capecitabine, a gentle, oral, less toxic regimen. But this was a negative trial. Unfortunately, the capecitabine arm was clearly worse in terms of relapse-free and overall survival and has not replaced standard chemotherapy. A second relevant trial was not specific for older people, but is relevant because it compared TC, docetaxel cyclophosphamide, versus AC, showing clear benefit for the TC in terms of relapse-free and overall survival. And also in sub-analysis, it was quite well tolerated. And this study was followed by several studies looking at the TC regimen more specifically in older patients. So these are two additional studies looking in 70+ patients. And it seems that if you decide to give this regimen, it's feasible in more than 90% of your older persons. Quality of life and clinical frailty can decrease somewhat at 3 months, but it recovers by 1 year if you measure it then. So my conclusion is that TC is a feasible regimen for the majority of older patients where you and the patient decide that you want to give it for some reason. Going into the subtypes, luminal cancer, adjuvant endocrine therapy has been shown to be beneficial, independent of age, for overall survival benefit. In contrast to chemo, this is from the EBCTG overview, you see that the mortality reduction remains over time. And of course, as discussed, primary endocrine therapy can also be an option if immediate surgery is not suitable or desired for some reason. Chemotherapy in luminal disease. For young patients, this is well established. We use adjuvant chemo in high-risk patients, clinical high-risk, luminal B-like, high oncotype or mama print. But what about older people? Well, we had the very elegant Aster 70s trial presented at ASCO 2 years ago. This study included patients 70+ with a luminal breast cancer and a high genomic grade index. They were randomized to chemo or no chemo plus endocrine therapy. And in intent to treat, the 4-year overall survival was not statistically significantly better than with the chemo. But there are some points of attention in this study because median age was 76. 40% had a G8 score 14 or lower, so they had potential vulnerability. And I think those are patients that I would be very reluctant to give chemo anyhow. There was a lot of low-stage tumors, 70% of lobular cancers, where we know the benefit of chemo is low. There was non-adherence to the treatment assigned in 20% of patients. A large proportion didn't follow the randomization arm that was proposed. And they did a per protocol analysis additionally, and in the ones that received the treatment assigned, and there the difference in survival was significant. Chemo was stopped prematurely only in 6%. This again, and it was mainly TC, again confirming that if you want to give chemotherapy, TC, and the patient agrees that it's feasible, and endocrine therapy was more often stopped than chemotherapy prematurely. My conclusion is that adjuvant chemo for luminal disease is rarely needed unless you have a high-risk tumor and a fit patient. I hope the study will be published soon so we can look more in the details and the subgroups that may or may not have benefit. In terms of luminal disease, the adjuvant CDK4/6 inhibitors have come into play. Monarch E study showed benefit in the general population, and there was also an age sub-analysis a year ago showing benefit also for older patients. But if you look in depth to the numbers, you see more problems with older people, more diarrhea, fatigue, treatment discontinuation, and treatment adjustments, and only 15% were 65+. This is the selection bias I was referring to. This is not representative of the whole older population. So what about giving a CDK4/6 inhibitor instead of chemo? This is asked in the Appalachians trial under the umbrella of ERTC and the Breast International Group. It's comparing chemo versus Ciclip, and we hope to have results end of next year or beginning 2026. In triple-negative early disease, in young patients, it's easy these days. You give Keynote 522 for stage 2-3 disease. We don't have any trials for older people. In retrospective subgroup analysis, we see more chemo benefit in triple negative versus the luminal tumors, but we certainly need to have a look at the subtype. Older patients have different triple negative tumors, more androgen-driven or rare subtypes where the chemo benefit is less. So if you want to give chemo, it's again not advancing, yeah. Keynote is probably not feasible for the large majority. I think you will kill patients if you give that to the majority of your 70-year-old person. You can give docetaxel cyclophosphamide or give a de-escalated chemo regimen, but there are no data at all omitting the anthracyclines from the keynote, for instance. Just briefly, because if you give immune therapy to older patients, you need to be aware of toxicity. And SIOC, the International Society of Geriatric Oncology, will publish a guideline on the use of immune checkpoint inhibitors in older people with some specific recommendations and points of attention, because older patients may have more problems if they develop side effects. HER2 positive, in young patients, this is the TCHP regimen for the majority, but it's probably not feasible for the large majority of your older patients. BCRG06 excluded those 70 plus. We often need de-escalation. It can be avoidance of anthracyclines and carboplatin, and we have to de-escalate, but there are hardly any trials available on how to optimally de-escalate, and I put some examples here or refer to the publication. So in metastatic disease, having a look at luminal disease, in young patients, this is easy. We give endocrine therapy with a CDK4/6 inhibitor. There are some age sub-analysis on CDK4/6 inhibitors in older people, and we clearly see that the PFS and the OS benefit, if present, is independent of age, and that the 3 CDK4/6 inhibitors have similar benefit. There is some increase in side effects. In observational studies, we see more upfront dose reductions or reductions during treatment, but quality of life is generally remains stable. In older people, the results from SONIA trial are even more relevant than in the younger population. We can certainly consider to give the CDK4/6 second line rather than first line. Beware of drug-drug interactions, and I think the choice of the CDK4/6 inhibitor also relies on comorbidities. In triple-negative disease, first line in the young population, we give chemo with or without anti-PD-L1 for most. You can also apply this for older patients, but have a look at the subtype because often they are different. And you can consider the standard treatments, but you will encounter more toxicities. Sacituzumab govitecan is an established second-line treatment, but we have very few data in older or frail persons. And there are some other options without strong evidence. I could have left the slide empty like my previous presenter, because we don't have any hard data here. In HER2 positive metastatic disease, we give taxane, trastuzumab, pertuzumab for most in first line in the young ones. You can give the same treatments, but you can certainly consider treatment de-escalation. You can give an aromatase inhibitor with dual HER2 blockade. You could consider metronomic cyclophosphamide in the ER negatives based on the RTC study. And today we heard the Patina trial, I think, where in the ER positive, HER2 positive population, a CDK4/6 inhibitor was given as maintenance with highly impressive results. So there were a lot of options to de-escalate your treatment. But still, if you give anti-HER2 therapy, the large majority of older patients die from breast cancer. So it's not because they're old that they can't die from the disease. In second line, we have TDXD established, and there was an age-pooled analysis on Destiny Breast 1, 2, 3 together, showing that the PFS rate and response rate and relative dose intensity was quite similar in 65 plus and below. There was some increase in toxicity, but there were very few patients, once again, above age 75. So this is certainly not a statement that you can give this to any frail person sitting in front of you. It can be used in older persons, but we definitely need more data on optimal dosing and use in frail persons. So, in conclusion, for early breast cancer, older persons don't need the same treatment as the younger population. There is less gain from chemotherapy, adjuvant chemotherapy or neoadjuvant. There is higher chemotoxicity, there is influence of comorbidities and competing risks of death. And there is this balance of over-treatment versus under-treatment that we have to make every day with our patients together. In metastatic disease, quality of life and patient preferences certainly dictate treatment choice, besides the tumor characteristics. We need much better ways to study new anti-cancer drugs in frail persons. This is really insufficient at present. Geriatric assessment is the cornerstone for personalized care, but implementation is a big challenge in the daily clinic. And I want to end with this quote from SABCS: every oncologist, every healthcare worker has to become a geriatric oncologist. Thank you for your attention.
Thank you so much. All right, now we're going to open it up to questions and answer. So you can either use the mic or you can use the app to put in your questions. All right, we have some questions in the app. Oh, go ahead. You have a mic? Yeah, go ahead.
No, my name is Barbara Segar. I'm a patient advocate. I want to excuse the patient advocate that was going to be there, but we have one. She
perfect.
Came up with an illness, but she's going to be able to contribute to it if you want.
Perfect. Do you want to introduce yourself, Sandy?
Yes, actually, my name is Sandy, but I'm not Sandy Stafford. I'm not even the same league as Sandy Stafford, but I have very strong opinions about being old, because I am, and I want to applaud all of you. First of all, I want to applaud you for being here, because it means you care, and I think this is something that really needs attention. As been mentioned, populations are aging, and age to me is just a number.
Thank you. All right. As people are coming up to the podium, I have a couple of questions here, and I thought I would ask. So one of the audience member asked, is the difference in PCR with age related to chemotherapy regimen or inability to complete chemotherapy?
It's probably not related to chemotherapy regimen, because in this sort of pooled analysis of the GBG data, the chemotherapy was balanced. So these were randomized trials. But obviously, so the more aggressive chemotherapies with more drugs piled on top of one another have higher PCR rates. But the tolerability is declining as one is getting older. But again, the age alone doesn't define that. So that's the challenge in this whole field, that there is a much larger difference between two 75-year-old individuals than between two 40-year-old individuals.
Great. The next question is about the talk that Christina gave. Do you use prehabilitation programs for your more frail older adults before surgery? And if so, can you share your experience and what evidence you consider?
I wish we had the resources for that. We don't. I've often thought that the rise of the use of neoadjuvant endocrine therapy in our postmenopausal populations is a very nice opportunity to actually prehabilitate some of these older women, but we have not been able to actually implement a prehabilitation program as of yet.
All right. Go ahead, you have a question.
Aaron Margulies, I'm a breast surgeon from Knoxville in private practice. I've heard talks about using the G8 scale in fit versus frail versus looking at someone's life expectancy. as a surgeon and I'm trying to decide whether to take someone to surgery or not, am I better off looking at their fit or the life expectancy, or how do you merge those two?
Yeah, so I think this is a question that always comes up, right? And there are a number of different, one, frailty screeners, and then two, ways of getting at life expectancy. And I think they actually have, they should function in different ways, right? So we know from our literature that being frail predisposes them to higher rates of complications. Now, when we think about the complications from the surgeries that we do, the rates are still very low, and I still think our bias is to probably take them to surgery as long as we can support them through that process. I think that those, if someone screens positive for frailty, what I'm really thinking about is if they were to have a complication, what are the supports that they may have in place to help them get through that, right? So really taking some more time to understand what their social support is like, and really taking more time to educate them about what they're looking for in terms of potential complications after surgery, such that if something does come up, we catch it early. I think with respect to the life expectancy scores, that's really talking them through the whole menu of options that I was talking about. So thinking about the intensity of therapy as a whole.
Thank you.
Do you want to add anything to that, Hans?
I'd like to ask a question. So I mentioned I have strong opinions. It's distressed me for a long time that age determines whether you participate in a clinical trial or not. But you also need to understand who actually gets cancer, and it's an older population. So how do you as clinicians manage that the prescriptive medication is based on that younger population, that treatment is? Or does that put you in sort of an uncomfortable position if you're not giving the patient the prescribed amount of medication, as was mentioned by this gentleman, that not patients can't handle that?
Yeah, I feel often uncomfortable with by giving potentially toxic treatments because there's a big debate, as I show you, on what is the optimal dose even in older patients, and I try to develop trials on optimal dosing and up titration in older persons, but it's extremely difficult to find funding for that. Pharma industry does not seem to be interested or even afraid of testing this. I'm not sure what the problem always is. I think they're afraid of having an optimal dose that's lower than the recommended dose in the SMPC, and it's extremely difficult, but many oncologists, and me too, we start with a lower dose and we up titrate because primarily we want to avoid treatment-induced toxicities in any setting in older persons.
There's a question in here that's a follow-up for that, is do you use any of the assessments that were discussed today for dosing?
No, there is no data around. There is one drug that I know, it's everolimus. The Germans have done an up titration study because the normal dose is 10 milligrams and they started at 2.5 and it was feasible. And yeah, I often start at a lower dose and if it goes well, I up titrate, but it's really a data-free zone unfortunately.
Just to reflect on this, I think the challenge is that there is data to show both, that we undertreat older patients and they die because of that, they have recurrences. But there is also obviously data to the opposite as well. It happens that you overtreat people and harm them by the side effects. The challenge is that the right decision is a highly multivariable decision that's very hard to make in your mind. And it comes down to your life expectancy. It comes down to the probabilities or frailty, and each of these are actually multi-component or multivariable on their own. So I really hope that we could implement, or the EMR systems could implement, like e-prognosis, so that your patient actually has that in front of you, like we have BSA or BMI. So one could imagine that in the not too distant future, the EMR could actually tell you the e-prognosis. So what's that this person's life expectancy at 5 years, 10 years in the absence of cancer? And similarly, one could implement sort of frailty metrics as well, so that you have this in a somewhat objective manner, rather than just, I think she's too frail to get chemo, and my colleague says, no, she's okay, and we actually don't know the truth.
Can I add something on? Because we are now talking about geriatric assessment, and I think for many people it sounds like something strange and awkward. But if you look well at the geriatric assessment, I think that more than 50% of it is as relevant for younger patients. It's about vulnerability, and younger people can also have cognitive problems and social problems and functional problems and nutritional problems. And my own vision is that, and our hospital will now focus on it, we will develop a vulnerability assessment for all cancer patients. And if they are 70 plus, we can dive more in depth into specific domains. But most of the domains in the geriatric assessment are not age specific, in my view.
Do you have a question?
No,
Oh, there's a question. Go ahead.
Hi, my name is Julie Phelan from MGH in one of the community sites in Boston. I have a two-part question. The first question is a bit more practical. So I see a lot of things, including breast, but in terms of like physical exam, if there's one thing you would add, typically I do like ECOG score, get up and go, and if I'm being ambitious, have you fallen in 6 months? What's one thing you've explain a lot of tools that are available or upcoming? What's one thing you would add, if you could, to everybody's kind of armamentarium in terms of physical exam, in terms of kind of the whole patient, and deciding not just surgery, but chemotherapy, adjuvant therapy, radiation, to kind of the typical physical exam that providers usually do?
Should we all weigh in with one?
Yes, you can all pick your
We
favorite.
can all vote.
I mean, I think the right answer is the one that fits with your clinic flow, right? The right one is the one that you actually do. I suppose when I think about something that might be pretty easy to implement is gait speed. So I think that's been used a lot. And if you have the clinic space to just mark off 4 meters and just have someone time them, then that's a relatively easy thing to do.
I fully agree. There are hundreds of ways to do it, but it doesn't matter so much how you do it. It's just that you have attention for the different domains. And if you use a get up and go or any other test is good, as long as you try to have a global view on the situation and not only the cancer view.
Do you have a second question? You wanna go?
Yes, this is kind of more like the art of medicine. I've had a rash of patients who actually do not recognize that they are an older patient. So they want everything done, and they want my crystal ball, and they're mad at me when I say I'm not sure if you'll live to 100. So in that space, when they're not recognizing that they are older, how do you usually approach that? Because obviously this audience is very aware of being sensitive to patients who are not, the classic patient in clinical trials who are older. But if the patient is telling you they want everything, because they're looking at themselves as like 30s, 40s instead of 70s, 80s, how do you usually approach that?
Well, not to be gauche and try to recruit for a study, but you know what? This is actually what we're looking into. So some of my funded work is exactly on this, and how do we conduct these treatment conversations with these older adults, especially when there's a mismatch between what we think is clinically appropriate and what the patient really wants. And I think this is a skill that we really, really need to develop. And I do need more medical oncologists and radiation oncologists, as well as patient advocates, to help me with this work. So please, by all means, reach out to me. I would love to talk to you. All of that is to say that I don't necessarily have a great answer. I think my own approach to this is to try and slow down the conversation as the first step. right? And really think about these as multiple conversations. It takes a lot of time, and I get that, that's not what we have. But sometimes to get patients to the right choice, that time can really be helpful.
Just to add to this, though, shared decision-making would actually dictate that you take this into account. And oftentimes, these patients are correct. And you don't do the entire chemotherapy in one session, right? So you do this one by one. And eventually, the person may realize that this is actually really toxic and it's not for them, or may just see us through really well. And so I don't think that we have to be too paternalistic about this.
Thank you so much.
Thank you.
Mina, could I add?
Yes.
Yeah, go ahead, yeah.
I'm sorry. I would just like you all to remember that it's just as difficult for an 80-year-old to hear you have cancer as it is for a 40-year-old. The pain and the fear are the same. And I think that the 40-year-old is going to ask for everything just as much as the 80-year-old is. I would recommend, or I would encourage you to try and have advocates or patient mentors or whatever you want to call them in your facilities, so that that patient can have a discussion with the other patient that tells them, this really sucks. You may not want all of that, and it may not be appropriate for you. But an educated patient is going to make a very educated doctor.
That's great. That's very, very important feedback. Thank you for sharing that.
Yes.
Yes.
I was thinking about somebody mentioned about the cognitive impairment, and I was diagnosed at 42, and my brain was always very sharp. And almost for 2 years, I had ACT and then Taxol. And almost for 2 years after finishing treatment, I wasn't the same cognitive way. So I imagine as we get older, how, and I don't know if you guys have studied this, how people get confused, or now they have cognitive impairment because of the age and don't consider the chemo. And now I'm thinking I have an 86-year-old aunt who was diagnosed last year, and my cousin is saying now she has Alzheimer's. And I'm now thinking it could be from the chemo, because it happened to me when I was 42, and actually 2 years it took it back to come back. So your comments on impairment.
Well, the key, you had chemotherapy, I suppose. The chemo brain is, of course, a big issue and a big topic. It's maybe a topic for a session next year, a whole session. But it's certainly not only the chemo. It's also all the stress that surrounds breast cancer diagnosis, and the same attention problems are observed in breast cancer patients that don't have chemo. Yeah, it's absolutely, there are trials with MRIs and seeing subtle differences, but I don't think that people lose IQ points by chemotherapy. It's mainly an attention problem, I have.
But the unfortunate truth is that we don't have good ways to predict particular symptoms. So it's entirely possible that this old lady will have a major cognitive defect, but it's also entirely possible that she won't. That's the challenge.
There's a couple of questions on the chat here, on the app, that basically are all around the theme of clinical trial recruitment and low participation into clinical trials for older adults. And people want to know the panel's opinion on how would you change trial development to make it better for older adults so that the results are more generalizable to older adults? How would you approach the fact, maybe even strategy to increase recruitment in that population and to reduce exclusion into clinical trials? Can you comment on?
So maybe I take this because in another role I chair the SWOG clinical trial group's breast committee. So I think the NCI really made a very clear sort of direction that we shouldn't use age as an exclusion criteria. And I think the FDA needs to follow that too. So the historical reason why these patients were excluded was the idea that they somehow will sort of have a different pharmacokinetics and different sort of breakdown of the drugs. And once we show that the drug is safe and effective, then we will learn how to use them in the elderly. But I think that that is really a tenuous sort of argument. And I think that there is a strong movement to remove age restrictions and really define eligibility on the absolute necessary safety criteria rather than just 25 items that sort of grandfathered in from 15 years ago.
Maybe I can add on this, that ASCO did a great effort a few years ago already in GCO, several publications on recommendations to remove all the unnecessary exclusion criteria, and I think it's improved already. But still, it won't solve everything, because if you have a randomized trial and one of the arms is a heavy therapy, you will always have selection bias. You will always have inclusion bias that a patient, if the physician and the patient think they will not tolerate one of the three arms of the study, they won't go in those trials. And it's a catch-22 because if you cannot give the standard heavy therapy in a trial, then you don't have a comparison. And so it's extremely difficult to design trials for frail persons with standard therapy arms. I think it's often not possible to compare with standard Keynote 522. It's impossible in older patients to have such a trial. And you need specific elderly trials with specific regimens and specific questions.
Is it possible to have an arm that is age-specific, so the treatments are the same, but the analysis would be different based on age? Or is that too complicated?
I guess so. There is an age distribution, right? So there are fewer patients who are 85 or 90 than people who are between 50 or 60. So there is this issue that even if the distribution is entirely proportional to the age distribution of the population, then still, so the extreme age groups will be underrepresented. But one way to deal with that would need to be like an extension cohort, that you need to have a certain number of patients over 75 so that you can actually give some sort of a somewhat confident statement about the efficacy and tolerability in this group. Because even if we were accruing completely proportional to the age distribution, then the extreme age groups will be underrepresented because they are just not that common.
That's great. One more question that we have here. It says, it's not infrequent that patient decision be different from their family members. How do you suggest approaching these situations? It's tough.
Okay, you probably don't want me to say this, but I'm going to say it anyways. It's the patient's decision.
Exactly.
It's the patient's decision. My husband was diagnosed and he wanted me to make the decision for him. And I said, no, this is your decision. And I would hope families would do the same. I totally understand that they don't want to lose the parent or the aunt or the mother and that. But again, education is so important. So the conversation with the doctor can be with the family, and that might help solve the problem. But I think ultimately, it needs to be the patient's decision.
Yeah, absolutely. And legally also, it's the patient's decision that must take the priority unless a person is incapacitated.
Great. What are the best outcomes to measure in studies of older adults with breast cancer?
So you speak about endpoints in clinical trials, yeah. So SIOC wrote a publication on that, on optimal endpoints in trial design. And it's clear that the classical endpoints used in oncology, response rate and PFS, are not the endpoints that patients want or that give benefit. I think we have to be much more creative in trial designs. Quality of life should be an important aspect even of primary endpoints. I think you can construct co-primary endpoints that integrate aspects of quality of life or toxicity. So we don't need the same endpoints, I think, for trials in older persons.
All right. I think if there's no other questions, I think we'll end the session now. Thank you very much, everybody. Thank you to the speakers.
Thank you for joining.